Okay, so my remit was really to take a very kind of drill down on the safety data from the clinical trial experience. So, unfortunately, safety talks are hard to make really interesting because there's lots of tables, but I'll do my very best to open it up and make it as engaging as possible. The relevant conflict here is that I've either been a speaker for, designed clinical trials for, conducted clinical trials, written papers with AbbVie, Eli Lilly, and Pfizer, who make all of the relevant JAKs. So pretty much every aspect of that I've been involved in over the last 6 or 8 years. So those are relevant conflicts. So Iona's done a beautiful talk explaining the biology of JAK-STAT signaling pathways and their inhibition. And really, I'm not going to recapitulate this, but just to show that there's a very broad range of issues of signaling pathways relevant to atopic dermatitis that JAK1 in particular takes down. TSLP, IL-31, 4, 13, 22, which is involved in epidermal hyperplasia. But on the right-hand side, does this work? No, I don't know how you... Yeah. Oh, yeah, it does. So on the right-hand side, you've heard about interferons. And we talked a little bit about interferonopathies, where in single inherited disorders of immunity, you might get excess interferon signaling. JAKs can be kind of useful. That's off topic for today. But what's relevant for here is that interferon is obviously important in viral immunity, and you'll see some of the data on where that's relevant. So JAK inhibitors, which have been approved for atopic dermatitis, have varying selectivity. So you're used to the idea of monoclonals being incredibly specific, monoclonal antibodies having very specific epitopes, even on a single cytokine. So the binding site might be different for tralokinumab versus lebrikizumab, and so highly specific. JAK inhibitors are the medicinal chemistry of these is selectivity rather than specificity. So if you give a high enough dose in ex vivo systems, they actually have quite a lot of structural similarity, and you'll be able to inhibit all of them. However, the IC50, or the concentration that's required to knock down 50% of the activity, does vary quite a bit. And what we have, broadly speaking, is that baricitinib is more or less equally suppressive of JAK1 and JAK2, and not so much on TYK2 and not very much on JAK3. Abrocitinib is selective for JAK1, and so is upadacitinib, and you can see their relative selectivities for the other JAKs on their IC50s. So mostly we're using abrocitinib and upadacitinib in the clinic. So need to tell you a story. So the story about JAK safety really goes back to the approval of tofacitinib. Now, tofacitinib inhibits JAK1, JAK3, and a little bit of JAK2. It's equally on JAK1 and 3, and if you give high enough dose, it'll take down JAK2 as well. So the story of safety comes, and the relationship with the regulators goes back to tofacitinib being approved for rheumatoid arthritis, potentially with methotrexate as well, as in patients who were TNF inhibitor experienced and hadn't succeeded. So with the approval, the FDA insisted on essentially a post-marketing safety study, a PASS type study, which was called the oral surveillance study, and that was set up to actively enrich for people at risk of major adverse cardiac events and venous thromboembolism. So the FDA had concerns that tofacitinib could increase the risk of venous thromboembolism and major adverse cardiac events, and they asked the company to do a post-marketing safety study, and that was called the oral surveillance study. So to put people in that, they needed to load it for people who were more at risk. So everybody in this study had rheumatoid arthritis. Nearly all had previous disease-modifying drugs. They had at least one additional risk factor. Either they were a smoker, high blood pressure, low HDL, diabetes, history of coronary heart disease or family history, or extra-articular manifestations. This is a cohort which was loaded for events, and the endpoint was triggered by enough people having events, major adverse cardiac events. They needed 103, it's very specific kind of power calculation, and 138 malignancies, excluding non-melanoma skin cancer. And this was a randomization. It depended on which continent you were, whether you got etanercept or adalimumab as your TNF inhibitor, and there were 2 doses of tofacitinib. So that's how the oral surveillance study was set up. It completed in 2022, at the end of 2020. The data cut came out in 2021, and the FDA and other regulators started reviewing this in early 2022. So basically it was set up as a non-inferiority study. So the idea was that if you were in one of these high-risk categories and you took a TNF inhibitor versus taking the dose of tofacitinib, that you would not be less safe than the TNF inhibitor if you were on the tofacitinib. And the power calculation, again, I'm not going to go into it in great detail, was that there wouldn't be the upper limit was 1.8, and the combined tofacitinib doses exceeded 1.8, even though they crossed the 0, all tofa versus TNFI. And that was considered that they weren't non-inferior. Otherwise, there was a slight there was a concern that they were more at risk of causing major adverse cardiac events than TNF inhibitors in this selected group. And it's the same for malignancy. Again, a marginal signal over non-inferiority for malignancy. And what's interesting then to look at is the post hoc analysis of this. So trying to identify who are these patients that are getting the risks. And if you're over 65 or ever smoked, that accounted for 80% of the adverse events of special interest, the EAACIs in this tofacitinib group. So there's a big signal for age and a big signal for smoking. And the post hoc analysis, which was published in 2022, this is the overall population looking at the probability of patients getting major adverse cardiac events through the duration of the study, 72 months of the study. You can see overall tofacitinib is more likely to have a major adverse cardiac event. If you split it out into people who were over 65 or who ever smoked, there's quite a big delta between the 2 arms. If you look under 65 and never smoked, you see there's really very little difference between the arms. So there's an interaction really at a global level between age, smoking, and tofacitinib in this selected cohort for rheumatoid arthritis. And the same with venous thromboembolism. It's actually even more striking here in the top right-hand side, where we look at people over 65 who ever smoked. They are accounting for nearly all of the difference between the 2 treatment arms in the post hoc. And this is important, obviously, when you come to counselling patients and prescribing these drugs. And remember, this is tofacitinib. It's not used for atopic derm. And again, same for malignancy, although the malignancy signal is a bit less differentiated between the 2. We can see again, under 65 and never smoked, it's not so much of a differentiator. So for most of 2022, the European Medicines Agency had an ongoing review that went up through the PRAC and eventually got through CHMP and signed off by the European Union. And this essentially is now, because we're in Europe, this is where the risk minimization strategy for JAK inhibitors came out of all of those extensive reviews. So it's recommended in the following patients, only if no suitable treatment alternatives are available: over 65, at major risk of ischemic heart disease, heart attack or stroke; smokers, or those who have done so for a long time in the past. That's a kind of loose definition. There's no pack years or anything like that. Patients at increased risk of cancer, that's only use it if there's no alternatives. And with caution, patients with risk factors for venous thromboembolism, and reduce the doses in people who are at risk of venous thromboembolism, cancer, and major cardiovascular problems. So that's kind of in line with where the ETFA, the European Task Force for AD, is. It's not putting a hierarchy of you must use biologics first. And remember, these guidelines apply to rheumatology and gastroenterology as well. So JAKs are used in those inflammatory diseases too. So there's no you must try this first, because the original starting position was you had to try TNFIs first, and that was a very rheumatoid arthritis, inflammatory bowel disease thing. So the Medicines Agency looked at JAKs as a class that was across all conditions, including atopic dermatitis and alopecia areata. So some of the things, they're not really precisely defining the risks and there's a degree of patient and physician discretion. So let's just have a look then at safety studies for these. These are the 5-year data for upadacitinib at 15 or 30 milligrams, and there's 6,000 years of patient exposure at this point. So the registration trials looked at 2 single monotherapy, that was measure up 1 and 2, and add up, which had topical corticosteroids in them. People had a 16-week placebo period, and then they went to long-term out to 260 weeks, which is 5 years, and that data cut is now available. I'm going to show you some of that. The important thing to remember is it's only the first 16 weeks that you have a placebo-controlled period, and once you go beyond that, then you need a comparator group of people, and it's extremely difficult to do that across multiple countries, multiple ages, multiple ethnicities, multiple comorbid backgrounds, smoking, non-smoking. It's really hard to have a very reliable comparator group as you get out. But let's just go through this. So when we look at these patients, 2,683 who had at least one dose of 15 or 30 milligrams of upadacitinib, split fairly equally. You've got exposure adjusted data here now, so the longer it's the number of events per exposure is the way we're looking at safety here. In this group, about half of the people in the trials had at least one cardiovascular risk factor, and a half did not have any. And some people, had 3 or 4% had 3 cardiovascular risk factors. And then what we're looking at is the overview up to 5 years at the 2 doses, and we can see just a small dose adjusted serious adverse event, 6.7 versus 7.8 by the 2 doses. So they are a comparator against each other, because you're comparing 15 versus 30, and sometimes dose dependent AEs are incredibly helpful to give you a sense of what the signals actually are. And if I come into the dose dependent things, again, these are busy tables, so I'm just going to focus on a couple of things. Herpes zoster, you remember I mentioned interferon gamma, so you can see here there's a dose dependent between 15 and 30 up to a year, and that's replicated out to 5 years, with the higher dose having a higher risk of herpes zoster reactivation. If we look at malignancy, in the 1-year data there was a fair discrepancy between them, again low numbers, but that wasn't found in the 5-year data, and everything else is fairly flat between the 2 doses, with a small signal for opportunistic infections, which I'll drill into. So just a couple of things. What this is showing, the green dots are upadacitinib 50, the blue dots are upadacitinib 30, and what we're really seeing is a differentiation here in herpes zoster. So it's a clear dose dependent, whether you're 2 years, 3 years, or 5 years. So the higher dose has a higher risk of zoster. Non-melanoma skin cancer is pretty flat. The opportunistic infections, a marginal nudge for the higher dose, and serious infection, very marginal difference in the higher dose. If we look at malignancy, was not statistically significant, but there's a numerical trend towards the higher dose having malignancy other than non-melanoma skin cancer. So it's not, and you're going to see the same with abrocitinib. It doesn't reach statistical significance. Was it not sufficiently powered? Was it not long enough? But we're seeing a marginal nudge on the higher dose. Venous thromboembolism is completely flat. And then if we try and get some comparator populations, British populations, US populations, Danish populations, we're finding that the background rate for people who've got atopic dermatitis in the general population, if we look at malignancy, major adverse cardiac events, or venous thromboembolism, the rates do not differentiate greatly from background rates. And this is very imprecise science, because it's so difficult to have a really good comparator group. But we're not seeing a massive delta between those who are 5 years on these drugs and those who are in the background rate. But I think the most reliable data are the difference between 15 and 30 milligrams, because we know everything about those patients and their doses in the clinical trial setting. It's the most controlled way of looking at it. So what we see is eczema herpeticum is more common. There's a dose-dependent zoster, serious infections and opportunistic infections slightly more common. That would be TB and serious pneumonias. The dose relationship wasn't observed for non-melanoma skin cancer and malignancy, excluding non-melanoma skin cancer. It didn't reach statistical significance, but there's a little signal there. And the MACE, VT and malignancy are broadly similar, with some comparator background populations with all of the imprecision and uncertainty that brings. The other nice thing that you can do with upadacitinib, because it's prescribed for it's now approved for multiple indications and is in multiple trials coming through, including now alopecia and vitiligo, is you can have a look at the rates of adverse effects by disease group, which is kind of interesting. And this is a paper that we published last year just with all of these rates. I just pulled one little signal out for you, and this has got rheumatoid arthritis, psoriatic arthritis, angst-bond, and atopic derm. And this is just for zoster. So if you have atopic dermatitis, your cutaneous immune system is already imperfect, and you're more risk of having herpes zoster anyway compared to the background population. But what we see here, psoriatic arthritis, the lower dose, there was a signal for zoster, but we see a very clean separation of doses and generally more zoster compared to angst-bond, psoriatic arthritis, or rheumatoid arthritis. So this is an adverse effect that's important in AD, and it's dose dependent, more so perhaps than some of the other conditions. And we saw less marrow issues in the AD group when we compared less lymphopenia, less neutropenia. So that integrated analysis, adverse effects of special interest are generally low with the two doses, and there is a dose dependent signal around zoster. Abrocitinib, this is another integrated safety analysis, 3,800. Again, a very similar idea. They had some mixed dosing, consistent doses versus variable dose. It's complicated. You can get the papers. I'm not going to spend a lot of time going through the difference, but because some people had were re-randomized in the trials, and many parent trials came into the full-time long-term extension study, and the 5-year data are just cut by Pfizer. You're going to see them later this afternoon. So just to again come back to a few things of interest in this busier slide, the higher doses in the orange color and the lower doses in the blue, and you can see dose separation again. This is the herpes simplex, herpes zoster, clear dose dependent adverse event between the two doses. COVID-19 overlapping, these were trials were going on during the pandemic, and eczema herpeticum actually more common in the lower dose, so that's with overlapping confidence intervals. So maybe that just wasn't sufficiently powered to differentiate it. But again, a signal for zoster coming out. There are some differences in age as well. Pfizer have split these between over 65 versus 18 to 65, over 65 to less than 18, and 18 to 65 versus over 65. And over 65 consistently, there's more events, because there are more events than people over 65 anyway. And then when we look at geographic region, we do see some geographic regional differences as well. And people who are more likely to get zoster, there's age, geographical region, and absolute lymphocyte count, and prior history of zoster. So again, it brings in the question, should we be vaccinating vulnerable patients for this? And again, this just reports, it keeps coming out that we see the zoster signal for the JAKs. This is just looking again, Pfizer have split this. So Pfizer did the tofacitinib oral surveillance study, so they're very used to looking at this. Here we see if you're a current or former smoker, a difference in the venous thromboembolism risk, and a difference for malignancy that's quite significant for each of these. And again, this is just again comes back to how we counsel our patients. So it's important to select the patient and the dose, and you can do that with both of these JAK inhibitors. The safety profile was fairly consistent, but over 65, higher rate of serious adverse events, a greater rate of hematological abnormalities, a higher rate of zoster, more increased serious infections, and a trend towards NMSC and malignancy. And the drugs are very similar in that way. You're going to see this data, the 5-year data, at 3 o'clock this afternoon. That's been presented. I'm not presenting it, others are. So tune in and see that for the most recent data cut. It's going to be shown for the first time here. So now we have thousands of years of exposure to these two drugs. They're generally safe and well tolerated. Zoster is a consistent signal. All of the adverse effects are more common in people over 65, likely reflecting background rates. But as we saw in the oral surveillance study, that there's people who smoke and people who are over 65 and have a JAK inhibitor differentiate from TNF inhibitors. So there's something about older people and smokers that's really important, and that's important in your patient selection as well. So I'm just going to finish right on time. Thanks.
Question, comments from the floor? I will start. Do you foresee any modification in the regulatory safety minimization profile given the new data that we have? Maybe they will change a little bit the recommendations because it's a little bit exaggerated.
I think they'll be reluctant to change in the immediate future, because for 2022 the EMA was, the oral surveillance study was mandated by the FDA. The EMA had a little more permissive approach to JAKs when they were originally licensed, and then when the findings from oral surveillance got reported, it kind of put the EMA slightly on the back foot. So they spent a full year and they did a lot of really detailed deep dive on the data. So, and they're looking across all of the current and future disease areas where JAKs will be approved. So they want to be very broad, and I think we've seen deucravacitinib have a different regulatory response, but deucravacitinib is a different drug. I think for JAKs that are JAK1, JAK2, JAK3, I think they'll be reluctant to change that for quite some time, and I think it's fine. It does inhibit prescription of them, and obviously companies would prefer that it was more easy, but I think where the guidelines are very sensible. They do allow physician-patient choice, and it's about selecting your patient and shared decision making and all of those things that we're all supposed to be getting really good at. So yeah.
Okay, microphone number 2.
Thank you for this excellent talk. My question is related to the stoppage of therapy. So what has been your experience? So once you decide to stop therapy, do you just stop it, or you taper it, or you add some other treatment for that particular duration of time when you're tapering the doses of any of the JAK inhibitors?
Yeah, no, it's a great question. So with both of those drugs, you can have 2 doses. You can have a higher dose and a lower dose. And over 65, you're supposed to use a lower dose. Under 18, lower dose. But you do have flexibility in adults between 18 and 65 of using 200 versus 100 or 30 versus 15. So some people who have seasonal atopic derm, you can give them higher doses when they're whatever season they're most miserable, and lower doses when they're less miserable. But JAKs have a very short half-life. They're eliminated in 2 days really from the body, and the experience in people who have had really severe AD is that they will relapse quite quickly. Now, the only trial evidence for that is by Pfizer with abrocitinib, where they did a withdrawal arm after treatment with abrocitinib, and about 20% of people, even out to 52 weeks, didn't maintain their EASI-75 response. So they were like super responders. So maybe 1 in 5 people from the trial data will go off the drug and remain quite well. But that means 4 out of 5 would probably have some degree of relapse of their atopic derm. And JAKs, remember, the itch signal, IL-31, IL-33, IL-13, IL-4, the pruritogens signal through that. So it's a very fast on for itch, but it's also a fast off. So people will know if their skin is really good and they stop a JAK, a week later, if it's coming back, they will feel itchy before they have lesions. So it's they're not drugs that are remittive. I don't know, what do you think, Mariela, in your experience?
Yes, well, we also have to do the dose flexibility.
Yeah.
For ABO, we mostly start with the 200, and if it goes well, to the 100. And for UPA, we mostly start with the 15.
Yeah.
But I think going after JAKs, in most patients, in my experience, there's an exacerbation. But they recaptured your response, so yeah. Yeah,
and the recapture data has been done, again, that has been done, that withdraw and recapture of response has been done with abrocitinib, and it about 85% of people recapture their full response. And I think that Marielyn's bit on efficacy is important. If you look at network meta-analyses, the 30 milligrams of UPA is the most efficacious generally, then 15, then 200 of abro, then 100 of abro. Most of them come out in that range. So that's important to know as well. So generally start at 200 of abrocitinib or 15. That's kind of mid. They're the two mid ones. And then the upper pole for deeper efficacy is probably 30 of UPA and 100 of abro for the step down.
Okay, thank you. You were mentioning vaccination. Can you elaborate a little bit of that? How do you do it? How would you recommend it?
Yeah, no, so it's a great question. So there's no guidelines or there's no kind of labeled recommendation, but people who you think you're going to put on JAKs and who've had a previous history of zoster, I will get them vaccinated with Shingrix and recommend that they do that. I'll have a conversation with virtually everybody over 18. It's not licensed under 18. Its license is over 50 for everybody and over 18 if you're immune compromised, which is effectively you're creating immune compromise. So it can be offered to anybody over 18. There's just no data in kids. So they can, you know, in Ireland, people have to pay for it themselves, not covered. So there's a financial piece. But I do encourage people to do it, to think about it, because zoster is miserable and it's a really, people can be so happy on their JAKs, but if it gets zoster, it's just miserable and it's a really horrible condition. So I do recommend people think about it. People will make their own choices. It's not a deal breaker for me if they don't, but I will check their varicella immunity before they start as well. So if they don't have any primary immunity to chickenpox, then I'll vaccinate everybody for that. Okay. Most people in Ireland do have immunity. But.
Any other questions or comments? I think that we will go on. Thank you so much, Alan.